So children, let's start with chapter 43 of your Apurva Shastri Essentials of Microbiology, which is Miscellaneous Bacterial Infections of Gastrointestinal System. In this, we'll be covering Campylobacteriosis, Helicobacter infections, and Clostridium difficile infection. Okay, now starting with Campylobacteriosis. Campylobacter species cause both diarrheal and systemic disease. They are motile, non-sporing, microaerophilic, curved gram-negative rods. Human pathogens fall into two main groups. Primary diarrheal disease caused by Clostridium Campylobacter, jejuni, accounting for 80 to 90% of the total cases, and others such as C. coli, Upsaliensis, C. lari, C. hyointestinalis, and C. fetus. Extraintestinal infection caused by C. fetus. Epidemiology. Source: Campylobacter species are zoonotic, found in the intestine of many animals, poultry, cattle, sheep, and swine, and household pets, including bird, dog, and cat. However, animals are asymptomatic. Mode of transmission: Campylobacter is transmitted by the following routes: by raw or uncooked food products, ingestion of contaminated poultry, most common raw unpasteurized milk or untreated water, through direct contact with the infected household pets, oral anal sexual contact. Infective dose: the infective dose is small, less than 500 organisms can cause disease. Age: person of all ages are affected. However, C. jejuni infection is common to among children. In contrast, C. fetus infection is the highest in extremes of age. The developing versus developed countries. In developed countries, C. jejuni infections are hyperendemic and mostly present as asymptomatic infection, except for children less than 2 years age, usually symptomatic. Okay, now in developed countries, Campylobacter is the leading bacterial cause of diarrheal disease, more common than Shigella and Salmonella. Seasonality: incidences peak during summer and early autumn. Pathogenesis: Pathogenesis of C. jejuni is due to the expression of following virulence factors. Motility of the strain: possess single polar flagellum and exhibits darting motility. Capacity to adhere to host tissues. Reduce toxin, which play a minor role. Enterotoxin heat labile, similar to cholera toxin. Cytotoxin cytolethal distending toxin or CDT. Proteinaceous capsule-like structure S layer expressed by C. fetus. Clinical manifestation: incubation period of Campylobacteriosis varies from 2 to 4 days. The clinical manifestations seen are as follows. Intestinal infection is characterized by inflammatory diarrhea, abdominal pain, and fever. Degree of diarrhea varies from several loose stools to grossly bloody stools. It's self-limiting. However, the relapse is seen in 5 to 10% of untreated cases. Complication: mainly due to C. fetus developing mostly in immunocompromised host and at the extremes of age. Common manifestations include bacteremia, sepsis, meningitis, vascular infections, endocarditis, aneurysm, and thrombophlebitis. Campylobacter can precipitate the pathogenesis of various other diseases such as Guillain-Barré syndrome, mainly C. jejuni, serotype 019, irritable bowel syndrome, alpha chain disease, a form of lymphoma that originates in small intestinal mucosa associated lymphoid tissue. Now, reactive arthritis and other dermatogenic manifestation in person with HLA-B27 phenotype. Lab diagnosis: freshly collected stool specimen, rectal swab are the preferred specimens. Direct microscopy: gram stain smear of species may show gram staining. Gram negative bacilli, or S-shaped or spiral gull wing shaped. Dark ground microscopy demonstrate the darting motility of the bacilli. Culture: the culture media for Campylobacter are as follows. Transport medium: if the delay is expected, transport medium such as Carey-Blair medium can be used. Selective media: feces or rectal swabs are plated onto selective media such as Skiros selective medium, Butler's selective medium, Campy-Bapp selective medium. Culture condition: inoculated plates are incubated at microaerophilic condition, 5% oxygen, growth at 42 degrees Celsius. Thermophilic Campylobacter species C. jejuni, C. coli, C. lari can be differentiated from C. fetus, which is non-thermophilic. After 2 to 5 days of incubation, characteristic effuse droplet-like colonies are produced, which can be further subjected to conventional biochemical test or automated system such as Marlitov or Vitek or species identification. Molecular method. Automated multiplex PCR assays such as biofar film arrays available. Its gastrointestinal panel can simultaneously detect 22 different enteric pathogens directly from stool specimen including Campylobacter. So in the figure we can see the Campylobacter gram-negative spiral lots in figure A and growth on sclerose media in figure B. Okay. Now, treatment. Fluid and electrolyte replacement is the mainstay of treatment. Specific antimicrobial therapy is indicated only for severe infection for immunocompromised patients. Antibiotics used for treatment are for diarrheal disease, oral macrolides are the drug of choice, erythromycin or azithromycin, and ciprofloxacin or doxycycline can be used alternatively. Systemic or life-threatening infection by C. fetus, parenteral imipenem or meropenem plus gentamicin should be started empirically, but susceptibility testing then be performed. Helicobacter infection. Helicobacter pylori is curved gram-negative rod that colonizes stomach and is associated with peptic ulcer disease and gastric carcinoma. Pathogenesis. Colonization of gastric mucosa. Man is the only important reservoir host of H. pylori. It colonizes the stomach of 50% of the world's human population, 30% in developed countries to nearby 80% in developing countries. Children may acquire this organism from parents or from other children. The colonization is favored by following factors. Motility. H. pylori is highly motile, conferred by 4 to 8 unipolar flagella, which accounts to it to remain in the viscous environment of the mucus layer overlying the gastric mucosa. Acid resistance. It may be due to urease enzyme. It produces abundant urease that catalyzes urea hydrolysis to produce ammonia, which in turn buffers the gastric acid. Amidase and arginase may contribute to production of ammonia. Adhesins. Though most H. pylori remain within the mucus layer, a few 2% may bind to mucosal epithelium by expressing adhesion molecules such as blood group antigen binding adhesin binds to Lewis blood group antigen, adherence associated lipoprotein. Resistance to oxidative stress. H. pylori produces many detoxifying enzymes that protect the organism against the effects of oxygen-derived free radicals generated from the bacterium's own metabolism and the inflammatory defenses of the host. Induces pathological changes. Vacuolating cytotoxin VAC-A. H. pylori secrete VAC-A that includes the formation of vacuoles in the cytoplasm of epithelial cells. Cytotoxin associated gene A, CAG-A, helps the bacterium to modulate certain aspects of the host cell's metabolism, including cytoskeletal rearrangements, host cell morphological changes, expression of proto-oncogenes, and release of pro-inflammatory cytokines from gastric epithelial cells. Molecular mimicry. Lipopolysaccharide of H. pylori glycoprotein moiety is identical to Lewis blood group antigen expressed on gastric parietal cells, which may result in immune tolerance by down-regulating the T cells, induction of autoantibodies that cross-react with mucosal epitopes and contribute to the development of chronic active gastritis. Alteration in gastric mucus. Lipopolysaccharide also inhibits glycosylation and sulfation of gastric mucus, which may impede its protective function and increase the vulnerability of the epithelial surface to gastric acidity. Host factor. People with polymorphisms in cytokine genes, interleukin 1 or genes coding toll-like receptors are at increased risk of gastric adenocarcinoma. Environmental risk factors. Smoking increases the risk of ulcers and cancer in H. pylori colonized individuals. Diets high in salt and preserved food increase the cancer risk, whereas diets high in antioxidant and vitamin C are protective. Clinical manifestation. Acute gastritis. Antrum is the most common site involved. Cardiac end is not involved. Antral gastritis. It predisposes to duodenal ulcers. Pan-gastritis. It predisposes to adenocarcinoma of stomach. Peptic ulcer disease. 70% of duodenal ulcer and 50% of gastric ulcer are due to H. pylori. Mechanism of duodenal ulcer. H. pylori induced inflammation inhibits somatostatin producing D cells, increase gastrin release, increase meal stimulated acid secretion, induces duodenal ulcer and gastric metaplasia of duodenal mucosa. Mechanism of gastric ulcer, though not clear, however, it is believed that there is hypochlorhydria despite increased gastrin release. Epigastric pain with burning sensation is the most common presentation. Develops either following a meal, as in duodenal cancer, or empty stomach, as in gastric ulcer. Chronic atrophic gastritis, autoimmune gastritis, pernicious anemia, adenocarcinoma of stomach, gastric mucosa associated lymphoid tissue, malt lymphomas. All right. Now, protective role for H. pylori, colonization of H. pylori induced hypochlorhydria has an inverse relation with the occurrence of gastroesophageal reflux disease GERD, Barrett's esophagus, adenocarcinoma of esophagus, allergic disorders including asthma. Lab diagnosis of H. pylori infection may be established by invasive and non-invasive methods. Invasive test endoscopy guided multiple biopsies can be taken from gastric mucosa, antrum and corpus and are subjected to histopathology with Warthin starry liver staining. Sensitivity can be improved by the use of immunostaining with anti-H. pylori antibody. Microbiological methods: gram staining, curved gram-negative bacilli with seagull-shaped morphology. Culture is the most specific test for H. pylori, however, it's not sensitive. Commonly used culture media are Skiros media and chocolate agar. Plates are incubated at 37 degrees Celsius under microaerophilic condition, 5% oxygen. Identification is made by automated identification systems such as MALDI-TOF or by conventional biochemical tests such as urease test. Biopsy urease test, also called as rapid urease test, it detects the presence of urease activity in gastric biopsies by using a broth that contains urea and a pH indicator. It is rapid, sensitive, and cheap. Non-invasive test, urea breath test. Patient drinks a solution of urea labeled with radioactive C13 and then blows into a tube. If the urea produced by H. pylori is present, the urea is hydrolyzed and labeled CO2 is detected in breath samples by mass spectrometry. Urea breath is a very popular nowadays and non-invasive as and used in best test to detect live bacteria, more consistent and accurate test, most sensitive, quick and simple, used to monitor treatment response become negative after improvement. Fecal antigen coproantigen assay. It is a non-invasive test with 90 to 95% sensitivity and specificity, detects both live and dead bacteria, used to monitor treatment response, useful for screening of children. Antibody IgG detection by ELISA is used for screening before endoscopy and seroepidemiological study. Now the treatment of H. pylori. Treatment of H. pylori infection is indicated for active or past history of peptic ulcer disease, atrophic gastritis, malt lymphoma, following endoscopic resection of early gastric cancer. However, treatment is not recommended for asymptomatic colonizers or primary prophylaxis for gastric cancer because of risk of adverse side effects and development of antibiotic resistance. Usually, multi-drug regimes are used. Monotherapy is not useful because of inadequate antibiotic delivery to the colonization niche. The success of treatment depends on patient's close compliance with the regime, use of susceptible antibodies. Treatment regime: OBTM, quadruple therapy, omeprazole, bismuth subsalicylate, metronidazole, and tetracycline given for 14 days. OCM or OCA triple therapy, omeprazole, clarithromycin, metronidazole, or amoxicillin for 14 days. Used only if H. pylori clarithromycin resistance is low, less than 15%. Monitoring patients during treatment. Perform urea blood test after completion of treatment regime. If tests are positive, repeat the treatment course with the same quadruple regime. If urea blood test still remains positive, treatment is instituted based on the culture of endoscopy guided biopsy followed by antimicrobial susceptibility report. In this figure, we can see endoscopy showing the duodenal ulcer due to H. pylori. And in the figure B, we see the H. pylori black curved rods colonized on the gastric mucosa, visible by Warthin starry staining. Alright. So now let's start with Clostridioides difficile infection. Clostridium difficile is an obligate anaerobic gram-positive spore-forming bacillus responsible for unique colonic disease pseudomembranous colitis, which occurs almost exclusively in association with prolonged antimicrobial use. It was so named due to the unusual difficulties involved in the isolation of C. difficile. Taxonomically, it is recently placed into separate genera Clostridioides difficile. Pathogenesis. Clostridioides difficile is a major cause of healthcare associated infection, mainly in the Western world. In India, the disease is reported less commonly. It is associated with the following risk factors. Prolonged hospital stays. Spores are found in variety and widely in nature, particularly in the hospitals, and get colonized in the colon of patients. Prolonged antimicrobial use. This can result in disruption of normal colonic flora, which enhances the susceptibility of Clostridioides difficile infection. Cephalosporin examples have Trixazone are frequently responsible for this condition. Other antibiotics such as clindamycin, ampicillin, and fluoroquinolone, ciprofloxacin, are also implicated in hospital outbreaks. However, all antibiotics, including vancomycin and metronidazole, which are the drugs of choice in Clostridioides difficile infection, have been found to carry a risk of infection if given for prolonged duration. Toxin production. Pathogenesis is toxin mediated. C. difficile may be harbored as common cell in the intestine. However, only the toxigenic strains can cause pseudomembranous colitis. It produces two powerful exotoxin, toxin A enterotoxin and toxin B cytotoxin. Both toxin A and B are secreted in the intestine, glycosylated in GTP binding proteins that regulate the cellular actin cytoskeleton. Disruption of the cytoskeleton results in the loss of cell shape, adherence, and disruption of epithelial cell barrier, leading to diarrhea and the pseudomembrane formation. Infants do not develop symptomatic infection because they lack suitable mucosal toxin receptors, which usually develop later in life. However, asymptomatic carriage is documented. Host immune response may determine the outcome of the infection. Person developing strong IgG response to toxin A become asymptomatic carriers. Person with inadequate IgG response to toxin A develop disease. Other risk factors. Suppression of normal flora. Normal flora helps in converting primary bile salts to secondary bile salts, which in turn resist the germination of spores. Advanced age more than 65 years, immunosuppression, cancer chemotherapy, gastric acid suppression medications, malignancies and gastrointestinal surgeries, use of electronic rectal thermometer, hypervirulent epidemic strain recently arrived type B1 NAP1 027 has been described as known as hypervirulent strain as it produces higher level of toxins and causes severe infection. Fidaxomicin is the drug of choice. Clinical manifestations. Diarrhea is the most common manifestation caused by C. difficile. Other manifestations include fever, abdominal pain, and leukocytosis. Blood in stool is uncommon. Pseudomembrane is composed of necrotic leukocyte, fibrin, mucus, and cellular debris. It attaches to the underlying mucosa. It appears as whitish yellow plaque of size ranging from 1 to 2 mm to large enough to spread over the entire colonic mucosa. Relapse after treatment is common and seen in 50 to 30% of the cases. Lab diagnosis in the case definition of C. difficile infection comprises of more than equal to 3 unformed stool per day and isolation of bacilli followed by toxicity testing. Stool culture is done under anaerobic condition that at 37 degrees Celsius for 24 to 48 hours by using C. difficile specific selective media such as CCFA, cefoxitin, cycloserine fructose agar, or CCYA, cefoxitin cycloserine egg yolk agar. Stool culture is highly sensitive and specific. However, since C. difficile can colonize the GIT, only isolation is not enough to establish the infection. Toxin demonstration is more meaningful. Cell culture cytotoxin utilization assay. It is highly specific but not as sensitive as the stool culture and also has a long turnaround time. Antigen detection, various methods such as rapid test or enzyme immunoassay are available for the detection of C. difficile specific antigen in stool specimen, toxin A or B. Its detection in stool indicates the presence of toxigenic strains of C. difficile. Glutamate dehydrogenase GDH is present in both toxigenic and non-toxigenic strains, therefore called as C. difficile common antigen. Detection of GDH in absence of toxin A or B indicates the presence of non-toxigenic strains of C. difficile in specimen. Molecular methods such as PCR, real-time PCR, gene expert are available targeting genes for coding C. difficile. such as TCDA, toxin A, TCDB, toxin B, TPI, triose phosphate isomerase in stool. They are highly selective and specific with faster turnaround time. Colonoscopy is highly specific if pseudomembranes are seen. However, the sensitivity is low when compared with other tests. Histopathology. The histopathology of colonic pseudomembrane obtained by colonoscopy can be performed by hematoxylin and eosin stain. It is highly specific, but the sensitivity is very low. C. Difficile infection, antimicrobial therapy, mild to moderate case, initial episode, oral vancomycin or fidaxomicin is the drug of choice given for 10 days. Oral metronidazole can be given alternatively but is less effective. Fulminant cases, oral vancomycin plus IV metronidazole plus rectal instillation of vancomycin is recommended. Recurrent cases, the treatment options are for first recurrence, oral vancomycin or fidaxomicin given for 10 days. For multiple recurrences, taper and pulse regime after the 10 days therapy of oral vancomycin, 125 mg 4 times a day. The dose can be tapered over 2 to 8 weeks. Other modalities of treatment: intravenous immunoglobulin passively provide antibodies to neutralize the C. difficile toxin, primarily toxin A. Fecal microbiota transplant (FMT) can be considered for the multiple recurrent cases. It involves replenishing of the gut flora with donated feces from a screened healthy donor. Fidaxomicin is the macrolide antibiotic, can be used in initial and recurrent cases and also against hypervirulent strains. IV and vancomycin is not effective for C. difficile infection. Prevention infection control measures, broad spectrum antimicrobial should be stopped at the earliest. Infection control measures of contact precaution should be followed, such as strict hand hygiene, hand wash is recommended, alcohol based hand rubs are not effective. Isolation: patient should be placed in isolation room and transfer should be restricted. Ensure proper disinfection of floor surfaces, toilets and other soil areas using 1% freshly prepared hypochlorite solution. Expected questions now. Short notes on the diagnosis of Helicobacter pylori and Clostridioides difficile infection can be written. Question: most sensitive method of diagnosis of Helicobacter pylori is the urea breath test, and all the following drugs are indicated in Clostridioides difficile except just read IV vancomycin is not indicated. Okay, so this completes our chapter. In the next video we'll be carrying viral gastroenteritis. Okay, so thanks for watching. Like, share, subscribe.